Welcome to all. Dear friends, in my previous talk on Amavata, part 1, we had at length discussion on the fundamentals of Am and various aspects of Amavata, including its Nidan, Samprapti, Lakshan, as well as Sadhya Sadhyata. We also discussed that on the basis of similarity in the clinical presentation, Amavata can be well correlated with rheumatoid arthritis. In the present session, we'll be having a detailed discussion on various aspects of rheumatoid arthritis, right from its definition to etiology, pathology, clinical manifestations, diagnosis, investigations, and management of rheumatoid arthritis. Objectives of this discussion. By the end of this discussion, our undergraduate students will be able to understand the concept of Amavata as well as rheumatoid arthritis. They will be able to understand the etiology, pathology, as well as clinical presentation of rheumatoid arthritis. They'll be able to diagnose rheumatoid arthritis by using modern investigation tools and have basic knowledge of and understanding of these investigation tools, where these investigations are to be done, and they will be able to draw logical conclusions from the results which are obtained from these investigations. And finally, they will be able to understand the clinical management of Amavata as well as rheumatoid arthritis. Rheumatoid arthritis. RA is an autoimmune disease in which normal immune response is directed against an individual's own tissues, including the joints, tendons, bones, resulting in inflammation and destruction of these tissues. Now, this definition is very simple and self-explanatory, but still it requires a little bit of discussion. Like, RA is an autoimmune disease. Now, this word has got two components. One is auto and second is immune. We all know our immune system. This is our defense system, which basically, protect our body from various invaders. So whether these invaders are bacteria or virus or any other antigen, when they enter our body into our body, our immune system gets activated and it tries to kill those invaders. But here in this particular disease of rheumatoid arthritis, our immune system is directed against body's own tissues. It do not discriminate between self and non-self. It considers body's own self tissues, these connective tissues, as invader or as non-self, and starts acting against those tissues. That initiates the story of rheumatoid arthritis, resulting in inflammation of synovial membrane, resulting in active synovitis, and ultimately the cascade of various inflammatory process starts in our body. It's a chronic multi-system disease of unknown cause. The exact cause is not known. It's a multi-system disease. It's not the disease of joints only. It's a multi-system disease. That is why the term rheumatoid arthritis is not preferred nowadays. The term rheumatoid disease appears to be more appropriate because it's a systemic disease where almost all the systems of the body are involved, and the joints are one of the component which is involved in this particular disease. This disease is characterized by persistent inflammatory synovitis leading to cartilage damage, bone erosions, joint deformity, and disability. Persistent inflammation in the joints that results in damage of various joint articular structures, erosions, bone erosions, they also takes place, and ultimately joints are deformed and various deformities becomes inevitable as the disease becomes chronic. Now coming to epidemiology. RA affects 0.5 to 1% of the population. It is more common among females. The female to male ratio is 3:1. But this difference diminishes with age. In elderly population, this 3:1 ratio may be as good as 2:1. People of any age can be affected by this rheumatoid arthritis. The peak age of onset is 45 to 65 years, but it may start in the early age group of 20 to 45 years also. Smoking is one of the known risk factors for rheumatoid arthritis. Genetic factors also play a vital role in the manifestation of rheumatoid arthritis. We'll have some detailed discussion on genetic factors after a couple of slides. Now coming to the etiology of RA. As I earlier said, that the exact etiology of RA is still not known. the factors which are basically initiating the disease process of rheumatoid arthritis are not known to the community, not known to the scientists. But some are of the opinion that it may be virus, maybe bacteria, maybe some other fungi which is initiating this disease process. But there is no evidence in favor of this hypothesis. Still, the most common and acceptable hypothesis of regarding the etiology of RA is hypothesis of molecular mimicry. As per this hypothesis of molecular mimicry, as and when the antigen enters the body, whether that is virus or bacteria or maybe anything else, body's immune system respond to that by producing antibodies. Now the antibodies which are produced by the body's immune system against the antigen, basically to destroy antigen, and because of the similarity in the molecular structure of that antigen and body's connective tissue, on connective tissues, the antibodies which are primarily directed against antigen, they start destroying connective tissue. As the disease progress, antigen may or may not be there in the body, but because the connective tissues, they are the integral part of our human anatomy, so they will remain there. So antibody production becomes a continuous event, and these antibodies which are continuously formed, they keep on destroying the connective tissues, and the every system, every organ of the body which has got connective tissue is adversely affected by these antibodies. So that process of that vicious cycle of antibody formation and destruction of connective tissue keep on going, and that is the reason why the disease is chronic one. It almost stay throughout the lifespan, because the antibodies, their production becomes a continuous phenomenon. Now in this regard, actually still the scientists are thinking that basically it is some sort of infective pathogen which is initiating the disease process. But as we discussed in the Amavata Part-1 presentation also, that we believe that when Agni is reduced, hypofunctioning of Agni is there, Jatra Agni is there, the food is not properly digested, that is fermented and that is transformed into Am, the wish type of substance, and that Am that get access to the circulation through dhamanis. So that arm basically may act like the antigen, and that may initiate the antigen antibody the process. And the antibodies which are basically produced by the body's defense system against that antigen which is of GI origin, which that may be arm, these antibodies are maybe again misdirected towards body's own connective tissue, and that may be the scene. Now the scientists, the researchers have started thinking in this direction also, that this antigen may not be necessarily the infective pathogen, whereas it may be of GI origin and it may be arm. So this hypothesis is also strengthening the concept of arm. Now coming to the genetic factors. Genetic factors also play a very important role in the manifestation of rheumatoid arthritis. RA shows genetic predisposition in families. There is 4 times more incidence in first degree relatives like brother, sister, son, father, or father, daughter. 70% of the patients of RA express HLA-DR4. HLA-DR4 molecule of human leukocytic antigen allele. HLA-DR4 marker is present in WBC, plays a role in helping the immune system to distinguish between foreign cells and body's own cells. And this capacity of the immune system in distinguishing between self and non-self is lost in this rheumatoid arthritis, because it's an autoimmune disease, and that is the basic reason why the immune system, which is basically designed by the nature to destroy that antigen, that starts destroying body's own tissues. Now we'll talk about the pathophysiology of RA in a very brief manner. Increasing permeability of blood vessels in the synovial membrane takes place at the outset. This attracts several types of WBCs, including lymphocytes, to synovial membrane out of circulation. So these WBCs, because of the increased permeability of the cell, they gets accumulated in the synovial membrane, and that initiates inflammatory process over there. Synovial inflammation takes place, synovitis takes place, and the inflammatory granulation tissue, that is venous tissue formation, takes place, and ultimately that keep on progressively increasing in size, and that destroys the entire cartilage. Later fibrous or bony ankylosis may occur. The joint is totally disorganized. The muscles adjacent to the joint, they also get atrophied because of the persistent inflammation of the joint. These muscles and the periarticular structures, they are not used properly, and their disuse atrophy is also inevitable with the passage of time as the disease becomes chronic. Now here in this picture we can see the structure of joint which has been affected by rheumatoid arthritis. We can see the red inflamed synovial membrane. The joint capsule is also inflamed. Cartilage has been eroded. Pannus formation has begun. So all these changes, they do appear when the joint is affected by rheumatoid arthritis. Here again we can see the structure of joint which is involved in rheumatoid arthritis. We can see the granulation tissue which is known as pannus is that has appeared in the place, and this pannus keep on growing in size. Ultimately this erodes the articular cartilage. It occupies the entire articular area, and the joint is totally disorganized and ankylosed with the passage of time. Here also we can see that inflammation can also spread to the soft tissues and destroy these structures, leading to the laxity and deformity of the joints. Muscles, tendons, and ligaments are also adversely affected in rheumatoid arthritis. At the one end, because the joints are acutely inflamed, so their movement leads to pain. So to prevent that pain, patient try to keep the joint immobile, and because joint remain immobile for a longer duration of time, that results in disuse of muscles and tendons and ligaments, leading to their disuse atrophy. And at the other end, because these structures, the ligaments, tendons, they also contain connective tissue, and as we know that connective tissues, irrespective of the site, wherever they are present in the body, whether it is joint or it is eye or it is elsewhere, that is attacked by the antibodies. So being connective tissue structure, they are also attacked in rheumatoid arthritis. Now coming to the clinical features of RA. First we will talk about the onset of RA, how the disease starts, how it begins. In most of the cases, say in more than 90% of the cases, the onset of disease is very slow, is gradual, is insidious. Over a span of few weeks to few months, the disease keep on increasing in severity, and after a few weeks to months, it takes its actual shape, where different features of rheumatoid arthritis, they do appear, and at that particular stage, the clinical diagnosis of RA becomes possible. Whereas in 10% of the cases, there can be acute onset, where within few weeks, patient can develop a full-blown disease. Clinical features, they become evident, and the clinical diagnosis becomes possible. So that type of onset is again not very common. Very rarely, a hyperacute onset of disease can also be seen. That is also known as palindromic onset, where over a duration of 24 hours or 36 hours, joint inflammation starts and the joints are acutely inflamed. If that type of onset is there, that is very rare, and by and large, that type of onset is seen in gouty arthritis type of condition. It's very uncommon type of onset for rheumatoid arthritis. Although rheumatoid arthritis may present at any age, but the patients most commonly are affected in their 3rd to 6th decade of life. The pattern of joint involvement is also very peculiar in rheumatoid arthritis. In RA, mostly more than 4 joints are involved. That is the most common presentation. More than 5 joints are involved. That is most common presentation. This is also called polyarticular presentation. Oligoarticular presentation or onset can also be there, where initially 4 or less than 4 joints may be involved, and very rarely monoarticular onset can also be there, though that is very rare, where there may be involvement of single joint. And if single joint is involved in the very beginning, that by and large goes against the diagnosis of RA. In that situation, we have to rule out other conditions which may be responsible for arthritis, like tubercular arthritis, or say gouty arthritis, or infective arthritis also, or septic arthritis, what we call as, that is to be ruled out. Morning stiffness for more than 1 hour, which eases down with physical activity, is a very characteristic feature of rheumatoid arthritis. Involvement of smaller joint of hand and feet is also typically seen in most of the patients of RA. So at the outset, the joints which are involved in the beginning are the joints of smaller joints of hand and feet. Now, talking about the prodromal symptoms of RA, these features are quite non-specific. These features are like fatigue, anorexia, weight loss, muscle joint aches and stiffness, low-grade fever, generalized weakness. All these features may be there because of 101 reasons. Like weight loss can be there due to so many other reasons. There can be some infective pathology, and there may be some other reason like neoplastic conditions can be there which may be responsible for weight loss. Likewise, if patient is presenting with low-grade fever, again there can be 101 reasons behind that low-grade fever. It may be again tuberculosis, maybe again some other infective condition, maybe malignancy. Generalized weakness again can be there due to so many other reasons. So we have to keep in mind that in the very initial stage of RA, when patient is presenting with prodromal features, at this point of time, making diagnosis of RA becomes very difficult. Now you just remind about the सामान्य लक्षण of आमवात. अंगमर्द रुचि तृष्णा आलस्य गौरव जो रहा अपाक शून्यता अंगानाम आमवातस्य लक्षणम. So these features are quite similar to the prodromal symptoms of RA which have been described in modern literature. All the features, whether it is low-grade fever, or it is fatigue, or it is anorexia, or it is weakness, all these features have been described in Ayurvedic literature also while talking about Amvat. So these two disorders, basically Amvat and rheumatoid arthritis, they fall very close to each other on the basis of clinical presentation. Another feature which is very important, which has been mentioned in Ayurvedic literature, is Gatra Stabta. Stabdam chakrute gatram. Now that Gatra Stabta or stiffness again has been described as a very peculiar feature of rheumatoid arthritis also. So these features are very close to Amvat. Incidence of joint involvement in RA. Again, it is very specific and peculiar. The involvement of metacarpophalangeal joint, proximal interphalangeal joint of hand, and similar joint of feet are involved in more than 90% of the patients. Invariably, all patients of rheumatoid arthritis, they show the involvement of these smaller joint of hand and feet. Knee joint, ankle joint, and wrist joint involvement is also seen invariably in all the patients, in more than 80% of the patients. Shoulder in 60%, elbow joint in 50%, temporomandibular, acromioclavicular, and sacroiliac joint involvement is also observed in about 30% of the patients. We have to keep in mind that any joint which has got synovial lining may be affected in rheumatoid arthritis. Now just a remind of Pravardhamvat Lakshan. The involvement of all these joints, the involvement of Hast and Path joints, the involvement of bigger joints, involvement of sacroiliac joint, all these features have been described in relation to Amvat in Ayurvedic literature also. Now these pictures are showing the distribution of joint involvement in rheumatoid arthritis. We can see that involvement of metacarpophalangeal joint is there, proximal interphalangeal joints of hand are involved, and the similar joints of feet are also involved. Interestingly, the distal interphalangeal joints are never involved in rheumatoid arthritis. Again, this is a very peculiar feature. This distal interphalangeal joint involvement is seen in osteoarthritis. When the disease becomes chronic, the knee joint involvement can also be observed in rheumatoid arthritis. Course of RA. Again, we should have a good understanding about the course of RA also. The symptom of rheumatoid arthritis come and go depending upon the degree of tissue inflammation. When the body tissues are inflamed, the disease is active. And when the tissues inflammation subsides, the disease is inactive, and this is known as remission. So the remission and relapses are frequently seen in RA patients. It all depends upon the immune reaction. Remission can occur spontaneously with or without treatment and can last for few weeks, months or years. During remission, symptoms of disease disappear and the patient generally feels well. He's all right. He's free from the clinical features or sign and symptoms of disease. And again, when the disease becomes active, means when relapse is there, the symptom reappears. The course of RA varies among affected individuals. The period of relapse and remissions are variable, maybe weeks, months, or years. Arthritis is common during relapse phase, which is characterized by active synovitis, reflected by red, swollen, painful, and tender joints. So we should understand the natural course of disease. Ups and downs are frequently seen in case of RA. Means relapse and remissions are there, uh, seen in most of the patients, and the phases, the duration of relapse and remission phase is also very variable. So sometimes we can understand that even without treatment there may be remission. So making a claim of you know curing rheumatoid arthritis should be very judicious, because remission can be there spontaneous or it can be under the effect of medication. So if the remission phase persists for a very prolonged period, then we should make a claim. Otherwise, we should refrain from making claim that our treatment is that much effective that we have cured our patient. So that should be very careful and judicious. Now coming to other signs and symptoms of RA, the joints of hand are often affected in beginning of RA. These joints are swollen, red and tender. The joint swelling is due to active synovitis, as we discussed earlier also, that invariably in all patients of RA, smaller joint of hand and feet are involved. In this picture also, we can see the huge swelling at metacarpophalangeal joints. In this picture also, we can see the swelling at metacarpophalangeal joints. The wrist joint is also swollen. Now we can understand that in case of RA, chronic inflammation develops in various joints, whether it is hand joints or it is wrist joint or it is knee joint or lower extremity joint, other joints. And this chronic inflammation in various joints results in various structural changes in these joints. There is destruction of articular cartilage, synovial membrane is chronically inflamed, pannus formation takes place, and the joint is totally ankylosed sometimes. So with the passage of time, as the disease becomes chronic, various structural changes they do take place in various joints, and these structural changes in the joints results in some specific deformities like swan neck deformity, button-ear deformity, Z deformity of thumb, boasting deformity, boasting sign is also there sometime. So these deformities and signs are very specific of RA. We'll discuss about all these deformities one by one. Now this picture is showing swan neck deformity. Here you can observe the hyperextension at proximal interphalangeal joint, and the distal interphalangeal joint is flexed. So this is giving a characteristic, appearance of swan neck. So this deformity is again very specific of rheumatoid arthritis. Here again the X-ray is showing hyperextension of proximal interphalangeal joint and flexion of distal interphalangeal joint, which is known as swan neck deformity. This is millet finger. Millet finger is simple flexion deformity of distal interphalangeal joint. This deformity results from extensor tendon rupture. When this extensor tendon is ruptured, the extension of distal interphalangeal distal phalanx do not take place. Z deformity of thumb again is very specific of RA. Here we can see severe hyperextension of interphalangeal joint of thumb with flexion of metacarpophalangeal joint. So that gives a characteristic shape of Z to the thumb, and that's why it's named as Z deformity. This is button-ear deformity. This deformity is exactly opposite to swan neck deformity. In swan neck deformity, there is hyperextension of proximal interphalangeal joint, whereas in this picture you can see the flexion of proximal interphalangeal joint. Whereas in swan neck deformity, there is flexion of distal interphalangeal joint, and in button-ear deformity, there is hyperextension of DIP. So this deformity is exactly opposite to swan neck deformity. In this X-ray, again you can see the flexion of proximal interphalangeal joint and the hyperextension of distal interphalangeal joint. Here in this picture, we can see bowstring sign. The tendon on the back of hand may become very prominent. Ulnar deviation is also seen. The direction of prominent tendons is like a bowstring. So because of the atrophy of hand muscles, these tendons they become very prominent and they just becomes like a string of bow or धनुष के तार के समान जो है हो जाते हैं, and that's why it's called bowstring sign. Here in this picture we can see ulnar deviation of fingers. In this picture we can see hammer toe. The toe they becomes like hammer. So again this is a very peculiar deformity which takes place in. Here we can see subluxation of metacarpophalangeal joints, that is resulting in ulnar deviation of fingers. In this picture we can see all three deformities: swan neck deformity, bottom-ear deformity, and millet finger. This is millet finger where the extension of distal phalanx is not possible. This is bottom-ear deformity where there is flexion of the proximal interphalangeal joint and hyperextension of distal interphalangeal joint, whereas in swan neck deformity, opposite to bottom-ear deformity, here it is hyperextension of PIP and flexion of DIP joint is there. Now coming to the complications of rheumatoid arthritis. Rheumatoid nodules. These are painless nodules. Appears below the skin. They may be single or multiple and they may vary in size from few millimeters to centimeters. And usual sites are pressure points below the forearm and on the elbow. Again, here in this picture we can see rheumatoid nodules on the elbow joint as well as on the forearm. Skin complications of rheumatoid arthritis. These skin complications of RA includes atrophic skin. The skin becomes very thin, papery and wrinkled. It becomes very fragile and develops hemorrhages or subcutaneous hemorrhages can develop very easily on a very small trauma. The nail becomes rough and brittle. Palmar arrhythmia, palms may become red. Other complications are when the salivary glands and lacrimal glands are affected. That results in reduced secretions from salivary gland and lacrimal glands, resulting in decreased tear and saliva. That's why the eyes may become dry, the tongue and buccal mucosa may become very dry, and this is called Sjogren syndrome. Hematological complication of RA includes anemia. This is called anemia of chronic disease. There is normocytic normochromic anemia. The count of RBC, total count of RBC is less. Another condition is Felty syndrome, which is characterized by leukopenia, RA, and splenomegaly. This triad is there, means features of RA along with reduced WBC count and splenomegaly. This is called Felty syndrome. Nerve complications may include entrapment of nerves in the carpal tunnel, leading to carpal tunnel syndrome, where the ulnar nerve may be entrapped and that may result in sensory as well as motor neuropathy. There may be atrophy of thinner and hypothinner muscles. Baker cyst is again a very peculiar feature of RA. This formation of Baker cyst is there because of herniation of posterior capsule of knee joint. A cyst filled with joints fluid and located in the hollow space at the back of knee. When the knee joint is extended, then this cyst becomes quite visible. Respiratory complications include formation of nodules in the lungs, and these can be reflected by X-ray and can be better reflected by CT scan. Other respiratory complications include pleural effusion. Again, pleural effusion is not very uncommon in RA patients. Now this X-ray film is showing massive pleural effusion in the right pleural space. Ocular complications of RA are also not very uncommon, especially when the patient is having seropositive RA. These complications can be seen, like this picture is showing keratoconjunctivitis sicca, where the eye becomes quite dry. This picture is showing the features of episcleritis. Here you can see the scleritis. This X-ray is showing the lytic changes in the bones. These are punched out lytic changes. Here it appears that as if the bone has been removed by using punch. So these changes, they do appear in a very aggressive patients, those who are having severe seropositive rheumatoid arthritis, and specifically these changes, they do appear in the very early stage of the disease. Now this X-ray is showing a totally deformed knee joint. Joint space is totally lost. Cartilage has absolutely been destroyed. This X-ray is showing arthritis changes in the hand, showing bony erosions. Bone displacement is also shown. Here this X-ray is showing arthritis changes in the foot. Dislocation of toes has been shown in this X-ray. Now we can well understand that in chronic rheumatoid arthritis patients, almost all the systems of body are involved, whether it is locomotor system, or it is nervous system, or it is respiratory system, or it is gastrointestinal tract, or it is cardiovascular system. In cardiovascular system, again, in heart, again the rheumatoid nodules may be formed in the heart tissues also. There may be involvement of cardiac valves, there may be involvement of conduction system of the heart leading to various conduction abnormalities. So different systems of the body are involved. We have to basically understand that every organ or every system where connective tissue is present can be adversely affected in case of rheumatoid arthritis. Now coming to the lab investigations in RA. So many investigations can be done in RA. But basically investigations are done to confirm the diagnosis as well as to see the complications. Like we can go with CBC, including hemoglobin and general blood film. We can go with acute phase reactants like ESR, CRP, rheumatoid factors, and TCCP can be done. For example, CBC is important investigation. Like these patients may have anemia of chronic disease where HB may be low, and in such condition, the general blood picture may show normocytic, normochromic type of film. Acute phase reactants like ESR and CRP can be done, though they are not very specific investigations for rheumatoid arthritis, but high ESR is and high CRP is definitely suggestive of high disease activity. And if ESR and CRP are low, then either disease is not present or disease, if at all it is present, is of low severity. We can also go with RA factor and anti-CCP. We'll discuss further. Rheumatoid factors. These are very important. This very important investigation which is ordered in RA patients. Rheumatoid factors are basically antibodies of IgM class. The sensitivity is about 70% and specificity is 80% in making diagnosis of RA. Rheumatoid factors are associated with more severe disease with extra-articular manifestations. If rheumatoid factors are present and they are present in high concentration, that usually indicates very high disease activity, and these patients are usually having extra-articular manifestations also. But regarding rheumatoid factor, we have to understand that if rheumatoid factor is positive, that does not confirm the diagnosis of RA. Rheumatoid factor may be present in so many other conditions also, like Sjogren syndrome, vasculitis, SLE, many infectious conditions like tuberculosis, bacterial endocarditis, and sometimes the elderly population above the age of 60 years. Few patients from the elderly age group may also have RA factor positive, though they may be absolutely healthy. So we have to understand that RA factor, if it is positive, it doesn't confirm the diagnosis of rheumatoid arthritis. And simultaneously, we have to also understand that if RA factor is negative, that doesn't rule out the possibility of rheumatoid arthritis, as the patient may have seronegative rheumatoid arthritis also. Anti-CCP. This is very important investigation in case of rheumatoid arthritis, though it's a little bit costly. This is IgG against synovial membrane. Sensitivity of anti-CCP is 65% and specificity is very high, it's 95%. It has got both diagnostic and prognostic value. If it is positive, it almost confirms the diagnosis of RA, and if it is positive in very high titer, that indicates that disease is very aggressive. Now coming to the diagnostic criteria, how to make the diagnosis of RA. Now, making diagnosis of RA is not always very difficult. Sometimes we can make diagnosis of RA even without doing any sort of investigation also. But we have to keep in mind this ACR criteria, which incorporates these 7 points. These points are: first one is morning stiffness of at least 1 hour duration. Second is arthritis of 3 or more than 3 joints as observed by the physician. Third one is arthritis of hand joints. Fourth is symmetrical arthritis. Fifth is rheumatoid nodules. Sixth one is positive rheumatoid factors. Seventh is radiologic evidence of erosions or periarticular osteopenia in hand or wrist joints. But the criteria number 1 to 4 should remain present for at least 6 weeks, and at least 4 criteria should remain present to make the diagnosis of rheumatoid arthritis. Let us revise it. Criteria number 1 is morning stiffness. We all understand that morning stiffness is one of the very important cardinal feature of RA, and it is invariably present in almost all the patients of rheumatoid arthritis. Second is arthritis of 3 joints, then arthritis of hand joints, and symmetrical arthritis. Now, if a given patient is having bilaterally symmetrical arthritis of both hands involving at least 3 joint areas, and simultaneously the patient is having the morning stiffness of more than 1 hour, and this arthritis is present for at least 6 weeks, then we can make the diagnosis of rheumatoid arthritis with confirmation. And if we do have the facility of doing investigation also, then we can go with this RA factor investigation. If RA factor is positive, that can further strengthen your diagnosis. We can also go with X-ray investigations that can also give aid to your diagnosis. Now, rheumatoid nodules, we all know that may remain present in some seropositive patients, and the site of presence of rheumatoid nodule is usually pressure site, the extensor surface of arm or elbow. But sometimes making diagnosis of RA becomes very challenging, especially in the early stage, when the patient comes very first time in the OPD, and the duration of symptoms or the duration of onset of this particular disease is less than 6 weeks. In that situation, the making diagnosis of RA becomes very difficult, because in the early stage the features are very non-specific, as I told while telling you about the prodromal features of RA and the Samanya Lakshan of Amavata also. The features are very non-specific, and making diagnosis in very early stage particularly becomes very difficult in RA patients. Now, the differential diagnosis of rheumatoid arthritis. Any disease condition where arthritis is present that need to be differentially diagnosed with RA. That may be gouty arthritis, that may be osteoarthritis, that may be like pyogenic arthritis, maybe tubercular arthritis, maybe sometimes neoplastic conditions like lung CA or gastrointestinal CA may also present with hypertrophic pulmonary osteoarthropathy. So these patients, they also resembles with RA patients. So we have to keep in mind these neoplastic conditions also while making diagnosis of RA. Now, lastly, coming to the management aspect. Rheumatoid arthritis is a disease which is very easy to diagnose, but it is not that much easy to treat. It is comparatively difficult to treat. In our Amavata first lecture, we already discussed that Chikitsa Siddhanta of Amavata was very first time described by Chakradat. It says, Langnam Swedanam Tiktam Deepnani Katunicha Virichanam Snepanam Bastasyam Marute. We again understand that it is basically hypofunctioning of Agni which results in formation of arm. So arm is the main morbid factor in the disease Amavata, and Langan helps in augmenting Agni, and this enhanced Agni can digest arm. So Langan has been mentioned as the very first line of treatment for management of Amavata. Then next is Swedan. In Bhav Prakash, specifically Ruksha Swedan. Baluka Swedan has been mentioned, and the Snehan has been specifically contraindicated because of the presence of arm. So this Swedan help in improving circulation to the involved joint, and that ultimately help in clearing the inflammation and reduces pain and swelling also. Next is use of Tikth and Katu Oshad. The Tikth and Katu Oshad, they do have the potential to augment Agni, and again because they do have Deepan and Pachan effect, so they increases Agni, they help in digestion of arm, and ultimately prove helpful in managing arm bath. Then next is Virechan. Specifically, errant tail has been mentioned for Virechan in case of arm bath. Doharitki can also be used. And lastly, Vasti with Sandwadi tail and Kshar Vasti has been specifically indicated by Chakradat in the management of arm bath. There are many single drugs which are effective in the management of arm bath. For example, Shunthi, Rasna, Punarnava, Kuchla, Ashwagandha, Lashun, Guruchi. These drugs can be safely and effectively used in the management of arm bath. Apart from that, various compound preparations can also be used. Punarnava Swaras can be used, Nirgundi Swaras can be used, and Rasna Panchak Kwat, Rasna Saptak Kwat, Rasna Dashmul Kwat, Punarnavashtak Kwat can also be effectively used in the management of arm bath. Different Churan preparations can be used like Pancham Churan, Ajmodadi Churan, Panchkol Churan, Trikatu Churan, they can also be used. Among different vatis, Sanjeevani vati, Agnitundi vati, Amavata vati, Amparmathni vati, Chitrakadi vati can be used. Simnath Google has been specifically indicated for arm bath. Though other Google preparations like Yogaraj Google, Kishore Google, Tyodashang Google can also be effectively used, and among different rus preparations, Mirpanak rus can be used, but these rus preparations are to be used very judiciously and for a restricted duration of time. And among different bhasam, Swarn bhasam can be effectively used. If the patient is simultaneously having anemia, then some low preparations like Novias low, Vidangadi low, Shilajitwadi low can also be used, and among various Sasavrist, Punanvasa, Dashmularist can be used. Different preparations can be used for the purpose of Virechan like Haritki Churan, Erand Tel. For Vasti, Dashmul Kwat, Sandwadi Tel and Narayan Tel can be used. Kshar Vasti is specifically indicated by Chakradat. For Lep, different preparations like Dashang Lep can be used in managing acute inflammatory condition of a specific joint. The goals of management are relief of pain, reduction of inflammation, preservation of function, prevention of structural damage and deformity to the joints, and lastly, the control of systemic involvement. To achieve these goals, we can use different drugs which we discussed earlier, either alone or in combination as per the requirement. But while selecting drugs, we should keep certain points in mind, like the availability of drug, the suitability of drug, the cost effectiveness of drug, and specifically, we know that it's a chronic disease where we have to give a very prolonged treatment. That is, treatment is required to be given for a longer duration of time. So initially, we should start with Kast Oshad because they are comparatively safe. And if the desired results are not achieved, then obviously we can select Ras Oshad also. But they are to be given very judiciously because the patient of rheumatoid arthritis, they do have involvement of many systems, and sometimes these patients may have other comorbidities also, so the associate preparation should be given very judiciously to these patients. Thank you. Thank you, friends.